Welcome, everyone, to this explainer on the endocrine system. Today, we are jumping straight from the microscopic world of biochemistry right to the clinical bedside. So grab your notes, because we're about to unpack the ultimate master controls of the human body, the exact molecular structures that dictate how we grow, and what happens when those incredibly delicate systems break down. And I want to give a massive special welcome to the medical students tuning in from King Edward Medical University, Chemo in the House. In today's explainer, our mission is to seamlessly bridge that gap between the foundational medical science you're grinding through in the lab and the actual clinical presentations you're going to face on the wards. Let's turn complex hormone biochemistry into actionable diagnostic knowledge. Here is our system-to-symptom roadmap. We'll hit the anatomy foundation, examine the blueprint of growth hormone, see physiology in action, explore clinical pathology, and finally wrap it all up with a case study challenge.
All right, Section 1, Anatomy Foundation. Let's map out these master controls.
So deep within the brain, the hypothalamus acts as the ultimate master coordinator. Right below it, suspended by the pituitary stalk, sits the pituitary gland, which is divided into two main lobes. The anterior pituitary is a true glandular structure, while the posterior mainly just stores and drops hormones that are actually produced higher up. And that physical connection via the stalk, it's absolutely vital for the chemical messaging we're about to decode.
Interestingly, the hormones pumping out of that anterior lobe basically fall into two distinct camps. On one side, we have tropic hormones, stuff like LH, FSH, TSH, and ACTH. These are kind of like middle managers. They travel to another endocrine gland and tell it to get to work. On the flip side, we have the direct effectors, growth hormone and prolactin. They skip the middleman completely and act right on your peripheral tissues.
This whole system is just incredibly efficient. Take the precursor molecule POMC, for example. It gets cleaved into ACTH, but the biochemistry actually doesn't stop there. ACTH itself can be sliced up further to produce alpha-MSH, or melanocyte-stimulating hormone. And this is a super important clinical pearl. An overproduction of ACTH means elevated MSH, which leads directly to skin pigmentation. It's a textbook example of molecular cleavage creating something you can see right there on a patient's skin. Moving to Section 2, the blueprint of growth hormone. Produced by specialized somatotrophs in the anterior pituitary, growth hormone is one of those direct effectors we just talked about. Check out that intricate 3D helical structure on the screen. It's structurally related to prolactin. It gets released when growth hormone-releasing hormone comes down from the hypothalamus, and it is actively kept in check by somatostatin. Let's break down the exact structural blueprint here. Growth hormone is a single-chain polypeptide. It is precisely 191 amino acids long, weighing in at 21,500 Daltons. And to maintain that highly complex 3D shape, it's locked down tight by two intramolecular disulfide bridges. That precise folding is exactly what allows it to bind perfectly to cell surface receptors.
But it's not just about structure. It is all about timing. Growth hormone isn't just constantly pumped out. It is secreted in distinct pulses. During the day, levels are pretty stable and low, usually under 2 nanograms per milliliter. But it spikes roughly 3 hours after you eat a meal or exercise. Most importantly, the grand peak of GH secretion hits about 90 minutes after you fall asleep, right during your period of deepest sleep. This is literally why proper sleep is strictly required for anabolic repair processes and skeletal growth. Without deep sleep, your body just misses its essential growth hormone surge.
Section 3, Physiology in action. Let's look at what this hormone actually does. Growth hormone operates through the JAK/STAT signal transduction pathway, acting as a massive biological amplifier. It travels directly to the liver and induces the production of insulin-like growth factors, primarily IGF-1. This drives sulfate into your cartilage, resulting in a huge enhancement in protein synthesis, increased bone growth, and more muscle mass. Metabolically speaking, it actively stimulates lipolysis to decrease adipose tissue and antagonizes insulin to raise your blood glucose. Basically, it's designed to build you up and provide the raw fuel to do it.
All right, Section 4, Clinical Pathology. What happens when these systems break?
So the absolutely crucial point here is timing. An excess of growth hormone, usually from a pituitary tumor, causes drastically different diseases depending entirely on the age of the patient. If that GH-producing tumor happens in a child before their bone growth plates, the epiphyses, have closed, you get gigantism. The patient grows to an impressive towering height like Robert Wadlow, who at 8 feet 11 inches tall. However, if that exact same tumor pops up in an adult after those plates have fused, they physically can't grow taller. Instead, they develop acromegaly, which results in dramatic bony and soft tissue overgrowth. When evaluating the systemic signs of acromegaly, just remember how GH acts on cartilage and soft tissue. In adults, this manifests as macroglossia, which is a massive enlargement of the tongue, and progressive prognathism, a noticeably protruding jaw. And because GH antagonizes insulin, these patients frequently suffer from glucose intolerance. It also causes organomegaly, especially enlarging the thyroid and the heart, which can eventually lead to progressive heart failure. These are just catastrophic results of unchecked biochemistry. To ground this clinical theory into physical reality, take a look at the spade-like hands characteristic of acromegaly. The extreme widening of the bones and that soft tissue overgrowth is just unmistakable. This dramatically alters a person's glove size and significantly cranks up the risk for nerve compressions, like carpal tunnel syndrome. It's a striking physical presentation you might spot the second a patient walks into the clinic.
We obviously also have to address the opposite end of the spectrum, growth hormone deficiency, or dwarfism. And this isn't just one simple malfunction. It can stem from childhood brain tumors like craniopharyngiomas that destroy the pituitary. It can also result from genetic defects like a mutation in the GHRH gene that tells the pituitary to secrete GH in the first place. Or, wild enough, you could have plenty of growth hormone, but if there are receptor mutations, say in the GH or IGF-1 receptors, the tissues simply become completely insensitive to the signal. In these cases, patients won't respond normally even if you give them exogenous growth hormone therapy.
Section 5. Clinical Case Study. Time to test your skills. Okay, CAMU students, here is your patient. A 48-year-old man presents to your clinic complaining of muscle weakness, headaches, and excessive sweating. His history shows poorly controlled hypertension. During the interview, he admits a gradual but definite increase in both his glove and shoe sizes over the last few years. You review older photographs of him and clearly document a coarsening of his facial features, a broadening of his nose, and progressive prognathism. Your suspicion of acromegaly should be incredibly high right now. Think back to the biochemistry we just mapped out. Before we order an invasive procedure, what initial screening tests are available to confirm our suspicion? How do we track down those biological amplifiers? Well, if you said testing for elevated levels of growth hormone, IGF-1, and IGF binding protein 3, you are absolutely correct. Because growth hormone induces the liver to pump out IGF-1, clinically checking those levels is the perfect initial screen. Elevated levels of IGF-1 and IGF-BP3 reliably point to a sustained, chronic excess of growth hormone circulating in the patient's system. Okay, so your screening tests come back highly elevated. But as excellent diagnosticians, you know we need to definitively prove that the pituitary tumor is acting autonomously, just completely ignoring the body's normal regulatory brakes. What is the definitive dynamic diagnostic test for autonomous GH production? It is the oral glucose loading test. Here is how it brilliantly leverages physiology against pathology. After an overnight fast, you give the patient a 100-gram oral glucose load. In a normal individual, a massive spike in glucose will suppress growth hormone levels down to undetectable amounts. But in our patient with acromegaly, who has a rogue autonomous tumor, when you measure their GH at 0, 60, and 120 minutes, the growth hormone levels stubbornly fail to suppress. That complete failure to suppress is your definitive diagnosis. We've reached the end of today's explainer, but I want to leave you with one final provocative challenge. Looking back at our 48-year-old patient, can you mentally reverse engineer the exact biochemical basis for every single symptom he experienced? Can you trace his excessive sweating, his progressive jaw growth, and his hypertension all the way back up to the JAK-STAT pathway and the fundamental disruption of his pituitary secretion? Keep building those bridges between the biochemistry and the bedside, and I'll catch you in the next explainer.